So we'll switch gears and go to the tiniest of our patients. We are the neonates, and I think this is a situation which some of you may encounter, and there's not much in literature of how to handle these patients. So I'm going to talk about some protocols and presentations based on our experience of more than 15 years. So when we look at neonatal pathologies, the infections are a significant group, and these could include the endogenous endophthalmitis. It also includes some of the viral infections. Today I'm going to talk only of the endophthalmitis. One thing is there that ophthalmia neonatorum, which is very common, is less common now, but you can still find cases of ophthalmia neonatorum, and it's very important to differentiate these from endophthalmitis. So any patient who presents like this definitely needs an ultrasonography for you to see, like is there something behind or it's just in the anterior segment. So what is important is that the endophthalmitis endogenous in these children is having the basic principles what we do for any other endophthalmitis, that's prompt diagnosis and clinical and microbiological evaluation, and then specific treatment depending on what infection we are suspecting. Always try to find the source of infection, and if there are other children around that baby, especially their twins, triplets nowadays we see from the NICU, then these need to be screened. The challenges is that many of these patients are hospital admissions from NICU, and they are very fragile, they are preterm, they may be systemically sick, and they may not be fit for general anesthesia. Many of these patients present to us, as I will show in the data, with already existing retinal detachment and necrosis, so they come in advanced stage. And so, really whether we should go all out and try to do an endectomy, vitrectomy, silicone oil injection in this patient, and is it going to give us better visual outcome, because there's going to be unilateral aphakia, dense amblyopia, you're going to remove the oil after a few weeks. So really the protocol may be different in these babies, because with all that you may not achieve any vision. Even if the eye is salvaged, the vision may be poor, and the eye will go into an esotropia and amblyopia. Sometimes the systemic cultures may be sterile, or they may be unavailable to you because it's already in some other hospital. And a lot of these patients are actually multi-drug resistant nosocomial infections, hospital acquired, who come to us. So what we learned over last 15 years was that a lot of these babies are premature babies who've been in NICU, and there are two types of presentations we see. One, which is a fulminant presentation, where patient comes with lydedema, adnexal reaction, chemosis, and you see very fulminant endophthalmitis. And a lot of these are Pseudomonas or Acinetobacter and gram-negative infections. And the other set is what you see on your routine screening. So, we go for ROP screening, or somebody calls us for screening the fundus, and this is what you see, a small white infiltrate in the retina somewhere, with there may be one or two satellite lesions, and the eye is very quiet, and there is no sign of any systemic infection or ocular infection. And these are Candida. You don't need a culture or a biopsy of these lesions. These are Candida, and you can treat them as Candida based on your clinical evaluation. So what we found was that all the patients who came to us with fulminant endophthalmitis, in spite of whatever we did, every eye went into phthisis. Whereas all the Candida eyes we could save based on our protocol. There was a publication from Bascom Palmer recently, and they had 4 or 5 Candida eyes, and all they lost. They lost all the eyes, and we've never lost a Candida eye in a baby. So just the protocol is a little different how we treat these patients, and that's what I'm going to show. So these are the eyes which we could not salvage, and interestingly, almost all of these patients, the mother has complained watering to the pediatrician or redness, and they have treated it as conjunctivitis. They have not even opened the eyes. They just look at the baby like that and say, okay, watering, discharge, okay, just put some antibiotic. They think it is NLD block, because overwhelming number of children in their nursery have this NLD block or conjunctivitis. So they don't have this idea that there's something called endophthalmitis. And after 2 or 3 days, when they notice that something is different, then they refer to us. So that is what we need to teach our colleagues in neonatology, that at least open the eye and look for red glow, or at least open the eye and look for the conjunctiva, cornea, what is happening. So by the time they reached us, so even this child, you can see here, this child, she was treated as conjunctivitis for 3 days. When she came, she already had a scleral abscess. So easily this could have been diagnosed by somebody, any physician could have diagnosed. It didn't require an ophthalmologist to diagnose. And all of them already had detachment, necrosed retina. So there's no point in going ahead and doing a, radical surgery in these eyes. So what we do for these patients who come with fulminant endophthalmitis and detachment already on ultrasound, where we know we can't salvage vision, we do under topical anesthesia. Just like you give Avastin, you do other things under topical anesthesia. These children are very small, they don't resist. Under topical anesthesia, you can hold them and do vitreous tap, aqueous tap, and inject the antibiotic. If the retina is already severely necrotic on your ultrasound, then you can actually inject extra dose of antibiotic, because now you're not worried about the antibiotic toxicity. The aim of treatment is to avoid evisceration. The aim of treatment is to avoid cavernous sinus thrombosis or orbital cellulitis with these fulminant organisms, and risk the life of the baby. This child had come with a shunt done somewhere for hydrocephalus, and patient was referred to me as stage 5 ROP because the eye was white and quiet and somebody saw leukocoria. He was only 3 weeks old. Now stage 5 ROP cannot occur in a 3-week-old. It usually occurs after 8 to 12 weeks or more. And we did aqueous and vitreous tap, and this grew fusarium. Now fusarium has not been reported in neonatal endophthalmitis, not a single case we could find. And then we told the pediatrician that possibly it's coming from the shunt. The shunt was working fine and the child was fine, but because of our report, they removed the shunt and it also grew fusarium. So I think what it highlights is that a close dialogue with the neonatologist is required, and we must find out whether there is any other blood culture report or urine culture, umbilical sepsis, any arthritis because they get septic arthritis, any cannulas which were put and whether they were cultured. So was there any candida epidemic in the nursery? Sometimes they have this epidemics. So we can get clues from other patients or other surroundings, and sometimes the old culture may be available for the patient and the endophthalmitis presents after a few days. So we can get the sensitivity report. So we should try to get all these reports, and based on those also we can modify our antibiotics. But what we want to highlight is that under topical anesthesia, you must take a specimen, because these are multi-drug resistant organisms. If you get the antibiotic sensitivity, then you can salvage and prevent eviscerations. As far as the non-fulminant group goes, as I said, these are clinical diagnosis. You don't need to do a vitreous biopsy. You can see it and you know this is candida. And again here we give intravitreal amphotericin B, and the dose I give is about 2/3 of the adult dose, just little less than the adult dose. There is no protocol. We don't know whether we should give adult dose to these small eyes or we should give little less dose. So I give nearly the adult dose, little less, and initially I used to do paracensis, but now I don't. I give an ocular massage and they take it very well. And then after a few days, once the child is fit for surgery, general anesthesia and all, because it takes time for the anesthetist to agree to, operate a child who is 1.2 kg or 1.3 kg, and you need to prepare them, their lungs should be good. Then we can do a vitrectomy if it doesn't resolve with the antibiotic. So this is the protocol. We take the birth and postnatal history of any microbiology reports. We can give empirical intravitreal ampho B, almost close to adult dose under topical anesthesia, and with that protocol we could salvage every eye who came to us with candida. We never lost any eye. The systemic cultures and the systemic antifungal is also very important. So even if we don't have culture positivity, but based on our clinical appearance, we can recommend that this is possibly a gram negative, so please go ahead and give systemic antimicrobial. Some patients have already received complete dose of systemic antibiotic before they present to us, so they may not need, but the systemic antifungals we give in consultation with the pediatrician. Usually they give fluconazole, and that can be continued for 6 to 8 weeks till whole of the infection has gone. So as I said, sometimes the patient may present to us with partially resolved infection because they have already received systemic antibiotics, and then we, on routine screening, we may find, or they may see some leukocoria and refer to us. So this is one patient who already diagnosed to have E. coli septicemia, was treated for it and came to us with this abscess and traction. Now this type of eyes who have traction, we must operate, because the vitreous, as the eye grows, the vitreous pulls on the retina, and this traction can keep on worsening. So you can see here, after the surgery, the folds have gone away and you've salvaged whatever was possible. Don't try to remove the subretinal component because it is coming from the choroid, and if you try to remove the subretinal component, you'll create a large macular hole. So you just need to do a core vitrectomy, just like you do lens sparing vitrectomy, and then it settles down, and then you give patching therapy. The other eye of this patient responded to the post-antisystemic antibiotics which he was receiving. I'm just showing here the retinal folds can be, confused with combined hematoma, which also sometimes these patients can have, but you can see the difference from the history and the abscess and the other eye involvement. So this is just to present the antibiogram. This is already published in European Journal of Ophthalmology, our series, that lot of these were drug resistant, so it's good to get the antibiotic sensitivity if we can, gram negative, and then we can give the appropriate antibiotics. And again, second time also you can give under topical, and you give along with steroids so that the eye quietens down quickly and you can, avoid evisceration. So important thing is that these babies get infected because of poor asepsis precautions. People don't use gloves while putting in the cannulas, and we do see a lot of this infection. So we need to, discuss with the hospital regarding good protocols for infection. Sometimes you can also have patient which looks like endophthalmitis, but it may have a viral retinitis, and they present exactly like adult acute retinal necrosis with vitreous haze. And this child was actually told by pediatrician that she has mosquito bites, whereas child was having herpes simplex. And mother was complaining of redness of the eyes, but they never opened the eyes to see. If they had opened the eye, they could have noted that there was something wrong with the cornea. But a lot of these children do get, treated with just conjunctivitis or an LD block. Whenever a child presents with any inflammation, retinoblastoma always should be kept in mind. However, it is very rare to see leukocoria as a presentation of retinoblastoma in a newborn. In newborns, retinoblastoma will usually present as a macular lesion, not as a total detachment in leukocoria. But I think that's very important that we mention in our ultrasound that there is no calcification, and that we are not dealing with retinoblastoma in any baby. So clinical evaluation, as I said, a red glow test we need to teach our colleagues how to differentiate and how to see that red glow in every patient before they just put them on antibiotics for some watering redness of the eye. The other thing is that they should be aware of any skin changes. That is one of the signs of underlying endophthalmitis. If there is lydedema, there is some chemosis, then you know that this is not just pure conjunctivitis. So the risk factor for poor prognosis were delay in diagnosis and treatment, infection with gram-negative multi-drug resistant organisms, and the factors leading to favorable outcome were early stage of disease and aggressive treatment with rational use of systemic and local, that is intravitreal, antibiotics. So I think this is an area which is less well recognized, but some of you may be faced with this as we are having more and more babies in our NICUs. 500 NICUs were opened in India in last 2 years. So you will be faced with some of these things, and I think everybody can handle these patients. There should be no difficulty. I'm happy to answer any questions.